Hey everyone, this is Victor from Cyborg for Life, and today I have a very special interview for you. He's the leader at the Center for Limb Lengthening and Reconstruction at the Mangal Anand Hospital in Chembur, Mumbai, India. Please enjoy the interview with Dr. Mangal Parihar. All right, everyone. Today we have a very special guest joining us. He is the leader of the Center for Limb Lengthening and Reconstruction as part of the Mangal Anand Hospital in Chembur, Mumbai, India. He is revered by his peers as the top reconstruction specialist in all of India, which is why patients from around the world go to him for his experience in the most advanced methods of limb lengthening, deformity correction, and even height enhancement to make you taller. Please join me in welcoming world-renowned orthopedic surgeon, Dr. Mangal Parihar. Hey, Dr. Parihar, how are you doing this morning?
Good.
It's afternoon there in India.
It's 5:30 now.
Wow, okay, I'll get that right. Well, first of all, thank you for joining me. Your reputation precedes you with so many raving fans, prospective patients, and other surgeons who speak very highly of you. I knew I had to have you as a guest. So before we begin, I just want to go through some of your amazing accolades over the years. You earned your medical degree from Seth GS Medical College and did residency at King Edward Memorial Hospital in Mumbai, India. You then followed this up with a fellowship in total joint replacement with Dr. Ranawat at Hospital for Special Surgery in New York, as well as one in limb lengthening and reconstruction with Dr. Paley when he was still at in Baltimore at the International Center for Limb Lengthening. On top of those your medical background, you also have been invited to speak at annual courses, workshops, and conferences worldwide in the UK, US, and India, and even other orthopedic disciplines, which goes to show why your philosophy of excellence and perfection suits you so well. So to lead off our discussion, I just want to start by asking, how did you become interested in pursuing limb lengthening and deformity correction?
Actually, during my residency, there was a lecture by a surgeon who was in New York when Elizarov conducted kind of the first course over there.
Mm-hmm.
So this guy was sitting probably in one of the first rows, and he had a whole series of pictures which Elizarov had projected. And when he came back to India, he kind of had a small meeting where he showed all of this work. And Elizarov in those lectures had some amazing, images. When I looked at that, that was something that I decided, oh, this is extremely interesting. And it was absolutely new at the time, somewhere around 89.
Mm-hmm.
And so I decided that, I'm going to look at this more in detail.
Mm-hmm.
Then I started looking up references as to, where I can learn it, and the name Paley kept coming up in all of the references.
Mm-hmm.
So then I decided that, okay, this is where I'm going to go and learn.
Wow.
I wrote to Dr. Paley and he kindly accepted me. So I was his second fellow, yeah.
Wow.
So when he was at Anand Hospital.
Okay, very cool. That's awesome. Well, that is cool because we know that limb lengthening and deformity correction, it's a very niche and specialized area of orthopedics. And not only have you saved the limbs of many patients, but you're also helping people improve their height, which is with cosmetic limb lengthening and stature lengthening. So do you believe, in your years of experience as a limb lengthening surgeon, do you believe that it's important that the surgeon has a background in deformity correction before they pursue cosmetic or stature lengthening patients?
I think so. Because, see, with cosmetic lengthening, essentially you're taking a normal person,
mm-hmm.
and you're trying to make him, longer. Mm-hmm. But in that normal person, if you lose even 5 degrees of movement in the ankle, let's say, you made that person abnormal.
Mm-hmm.
So I was always I've learned from all my gurus that function is more important than length.
Mm-hmm.
So and there can be all kinds of problems with limb lengthening. Once you are comfortable, once you are facile with the use of the Elizarov technology, and you can anticipate the problems. I think that's more important than treating the problem. So anticipating problems, preventing them, and all of that comes only with a certain number of cases under your belt.
Okay.
So it's kind of like, a pyramid.
Mhm.
You're doing all the general non-union kind of work at the base of the pyramid. Then there is deformity correction, more advanced deformity correction where we use, say, internal fixation. And cosmetic lengthening, I think, is right at the apex. Most of the people that I know who do cosmetic lengthening, at least a large number, cosmetic lengthening is a very small percentage of the entire work that they do.
Mhm.
It's not, it's not the be all and end all. I personally do cosmetic lengthening basically because there are a certain subset of people who absolutely want lengthening, who've done all their research, who know what the pros and cons, who know what the pitfalls are, and still want to get it done. And those are the people that I think should be taken care of, in the sense they should not land up with somebody who's not necessarily an expert in it, and therefore those kind of patients I will do.
Mhm.
Tend to be pretty selective in terms of how many that we do. I don't take anybody that comes in. I would say I first try to explain to them all, because a lot of them, especially in India, don't necessarily know the downsides of it, in the sense that they're going to be away from social life
Mhm.
for a while,
Right.
because that's not something that people like to advertise.
Mhm.
So when you're undergoing lengthening, and especially with earlier the external methods and all that, it was obvious that you're undergoing a lengthening. So they will have to be away from social life.
Right.
And a lot of those issues come into play.
Mhm.
So then these kind of people, once you explain all the negatives to them, they would not go in for lengthening. It's only a small percentage who have already done all the research, who know all the stuff that needs to be known. They then go ahead with surgery. But
Wow.
even having said that, I think my numbers overall compared to people in the West over here is much lesser.
I see. So when you select your patients, that you make sure that they are not only they understand they have informed consent, but is there any other type of psychological evaluation that you do with them?
Not really.
Okay.
One thing, we don't have any real psychological testing which is worth the name. And secondly,
Mhm.
I'm more interested in seeing that the patient understands what he or she is letting himself
Get
in
into.
for.
I see. Then.
If know what is possible, no patient goes through lengthening without a little bit of ups and downs. There may be pain, there may be some restriction of movement to start with,
Mhm.
and then they need to be pushed a little to get over that problem.
Mhm.
So as long as they understand what they are letting themselves in for,
Yeah.
then we can work together.
Okay.
If they come in thinking that, oh, this is going to be a walk in the park, and I'm just going to go, I'm going to have an operation, and I'm going to get longer. Then when they hit the first roadblock, then it becomes a problem, because this is something they didn't expect. Oh, I didn't know that there will be so much pain. I didn't know, I have to do this exercise and stuff. But the people who are who are knowledgeable about it, they they realize, okay, this is a problem. They work, and then it becomes more of a joint effort. So we are able to help them get over whatever roadblocks they have. So, but there's no specific psychological testing.
Okay. Very cool. Awesome.
And so, and especially since this is not one of my primary
Mhm.
objectives, in terms of it's not the way that I make a living.
Right.
Cosmetic lengthening is not the way I make a living.
Mhm. I see. Okay.
So I prefer, if I generally like to put myself in the patient's place.
Mhm.
If this were my brother, my sister, my parent, what would be the things I would be
Mhm.
telling him or her, and how would I be taking care of him or her. So I think patients deserve that much, that in terms of laying out everything, this is possible. Ultimately, especially in India, that tends to be there that, doctor, you know best. Yeah, I'm a doctor, but ultimately this decision has to be made between the two of us. The West carries it to a totally different degree. In the West, okay, this is option one, this is option two, and you have to select.
Yeah.
And there is this so-called informed consent. There is no such thing as informed consent.
Okay.
If I am sitting across to you and I tell you, okay, this is option A and this is option B, but sometimes in option A, this kind of thing, this kind of problem can occur.
Okay.
Option B also, there is a problem, but that's not a big deal. Now I'm already kind of priming you towards option B.
Right.
Okay. So yes, you lay out all the facts, but there is also a kind of unsaid information that is passing between the doctor and the patient.
I see.
Having said that, once I take up a patient, and I think most of us, not only me, most doctors who are good at their profession will do that. Once you've taken a patient on, that patient is your responsibility till that patient has finished his treatment, whatever it was. So I don't have 100% success rate. This is what I tell patients, that if I say I have a 99% success rate, it means that 1 out of 100 still has not succeeded. For him, the failure is 100%. But what I'm interested in is, okay, even if you have a problem, then I should be able to carry you through that problem and solve that. So there is the matter of trust. There is the matter of building a rapport. And a lot of our lengthening patients, they are not treatments which finish in 15 days. These are things which take a long time. You're lengthening, you're correcting a deformity gradually at 1 millimeter per day. That takes time. So over that time, there is definitely a certain amount of rapport that builds up between patient and surgeon. So that, I think, that part in a relationship between a doctor and a patient is important. And you can't let it go by not speaking the truth. When you speak the truth, it's very easy to build that rapport.
Okay. I like that. Yeah. Being truthful, the upfront, that's a very important thing. And when you do the procedure for cosmetic stature lengthening, do you perform the surgery on both legs yourself, or do you have another assistant doctor with you?
No, we have a team, but I do both sides.
Okay.
Myself. There may be some preparatory parts or ending parts, which will be done by my colleagues. One of my colleagues is very senior. He's a surgeon.
Okay.
In his own right. But for cosmetic is something that I do it both sides myself.
Okay. And
it takes but no way around it.
Right. When you have a patient come to you for cosmetic stature lengthening for a consultation or stuff, and they ask you about the amount of length they can get in the femurs or the tibias, what is the typical amount of length that you'll give them? Do you have strict limits in place, or do you just kind of have a lengthen and we'll watch what happened and make sure that we can prevent the problems along the way?
Yeah, I would usually tell a patient for tibias where you're doing, we were doing it with fixators and stuff, it would be 6 centimeters.
Okay.
After 6 centimeters, we found that the number of problems that occur, go up exponentially.
Okay.
Up to 5, almost everybody goes on without too much of a problem.
Okay.
5 to 6, they start getting tightness when they have to start working out more on the tendoachilles and stuff like that. So usually I say 6 centimeters. If you hit 6 centimeters well and things are going okay, we might try for more. Okay. But usually 6 is what I would say for. For the femur, that the precise nails that we've done, we've gone to 7.5 on all of them without too much of trouble.
Okay.
Sorry, 7.5 on two of them, 6 on the third one, but that 6 was because the patient didn't want anymore. Patient just wanted
Just
6.
one at 6. I see.
Yeah, he was doing well enough at 6, and he could have gone to 7.5 if he wanted.
Wow. And speaking of the lengthening devices that you use, so you use a combination of, depending on the patient selection, you have external and internal. Now, you have the precise nail there. Do you also offer the STRYDE nail, or do you not offer that right now?
No, it's if it's available,
Yeah.
which it is available now.
Yeah.
The patient can choose to go for the STRYDE. Exactly now, maybe for the next 15 days or a month, I'm told that the company is undergoing some kind of audit.
Yeah.
Therefore, the STRYDE is not available now. Precise 2 is now available. And in another 3 weeks or so, they tell me that the STRYDE also will be available. So there's that issue. The way it works, unlike in the US and remaining countries, the way it works here is they have a distributor. And because the numbers here are not a large amount, I think they have not, because getting it cleared by the Indian FDA takes time, effort, and money.
Right.
So unless you have a certain number of implants going in, it probably is not worth it. So currently, at least, there is a distributor in Delhi who, there is a specific method where for a particular patient, they get a license.
Okay.
So when the patient comes up, they get all the patient details, the patient pays the company, and they import it specifically for that particular patient.
Wow.
With one size up, one size down. So there's a whole bunch of implants which are flown in by air freight, and then they go out again. Once the surgery is done, they go out again.
Okay.
So that whole process takes about 6 weeks.
Okay.
It's not like in the West where it's kind of off the shelf.
Right.
So why a little bit of planning. Sometime in the future, things might change.
Right. So do you prefer that a patient consult with you, let's say maybe 8 weeks in advance, to make sure that they have that preparation in place?
Yes. I mean, if you consult me today, and you tell me that you want to have the precise or the STRYDE, you can't have it done before 6 weeks.
Okay.
If you tell me, Doc, I'm ready, then we put you in touch with the company, and then the company starts the work. And by the time, see, occasionally it may come in a little earlier also, but 6 weeks is like the safe limit. Probably somewhere between 4 to 5 weeks it gets in.
Yeah.
Then there's a little bit of a buffer
time. I see. Very cool. Very, very cool. And you offer other methods, obviously, for, let's say patients who may have either a partial deformity, like knock knees or bow legs, and still want lengthening, and or for budget constraints. What other methods do you offer at your center there?
We use the regular Elizarov.
Okay.
And we have 6-axis systems. That is what are called hexapods.
Okay.
So one of the famous hexapods in the West is the TSF. But we have a homegrown version known as the Ortho SUV. Okay. Which is actually a Russian device which was made in India under license. But effectively all 6-axis systems are the same. They have 6 struts. They have certain software to allow the manipulation of the struts, and they allow a precise change in length, angulation, what we call translation, that is side to side, as well as rotation. And all of these movements can be done with one set of sort of motors. With the classical Elizarov also you can do the same thing. Yeah. Except that with the classical Elizarov, for each movement, there needs to be a little bit of change in the hardware. So this makes it much easier for the surgeon, and from the patient's point of view, it becomes much more precise. I see. Using a 6-axis system. Okay. So we have the regular Elizarov, we have the hexapods. For some patients, we may use a monolateral fixator, similar to the OrthoFix, but a locally made one. But that's mainly for lengthening, bone transport, and that kind of thing, not so much for deformity correction.
Okay.
And nowadays, we also have locked plates so that we're able to correct the deformity with a fixator and then put a plate on so that the patient doesn't have a fixator for a long time. So there are multiple methods that are available.
Okay, very cool. And you as a surgeon, have you seen the different, obviously, I'm sure you've known the benefits between the external fixator and the internal nail. How has that been different for you? Has it changed the game completely from the precise? Yeah.
If anybody asks me what is the best method of lengthening, I would say today, if you can afford it, because in India, affordability is an issue. If you can afford it, then getting it with a nail, lengthening with a nail, is much better.
Right.
And when it started, I was wondering whether or not Indian patients would be able to afford it. But out of the 3 cosmetic lengthenings that we've done, 2 of them were Indian patients.
Yeah.
One of them was from the Middle East.
Okay.
And 2 tibial lengthenings that we've done, not for cosmesis, but limb length discrepancy. Both of them were Indian patients.
I see.
So it's still way beyond the the level for Indian patients to pay freely, but it is being done.
Right. I see. And Dr. Parihar, what type of prophylactic measures do you take for successful outcomes? So do you do anything like soft tissue releases or, like the IT band release or like a gastro-soleus release, anything like that during the procedure?
Yes. I mean, those are there are some standard things. If the gastro-soleus is tight, you can do a gastro-soleus recession.
Yeah.
All femoral lengthenings we will do through a small incision. We make an incision and excise, in fact, a part of the iliotibial tract.
Okay.
So that lengthening is not a problem. Range of motion is not a problem. Those are the primary soft tissue procedures that we do.
Okay.
Occasionally, if the rectus, etc., is tight, one may consider that. But I have not had a patient who has required that as yet.
Okay.
If anything that is tight to start with, it makes sense to release it through small incisions so that you don't have trouble with the lengthening later on.
I see. And let's say that a patient does have the precise nail done. What type of weight-bearing protocols do you have post-op? Because we know the precise 2 can handle a certain amount of weight. The STRYDE can handle almost a completely different. What type of protocols do you have? Is it walker assisted or what type of?
The first patient that we did was the first patient in all of India. Okay. So there we were extremely, conservative, in the sense I didn't want to take the slightest risk in terms of anything breaking, bending and stuff. Because it's a big expenditure anyways. And then on top of it all to have a complication. So there we were very, very, we approached things very gingerly.
Okay.
Other 2 patients, the next patient and the third patient, we had them standing, bed to toilet transfers with a walker.
Okay.
Not promoting them too much of walking. We were allowing them to stand so that, the foot remains plantigrade and stuff like that. And once we start seeing bone in the regenerate gap, then we start increasing the weight bearing gradually. But even then, it's with a walker.
Okay.
And only when I'm fully convinced that yes, there is good bone in the regenerate, then I shift them onto a pair of elbow crutches.
I see. That's very good.
I don't see any advantage per se for me. I mean, when we've got 50 under the belt, then maybe I would be more aggressive in terms of weight bearing. Right now, with this method, we are not having any problems with deformities. We are not having any problems with regenerate formation.
Mm-hmm.
Only thing is that patients may take a little longer to, but 7 months or 8 months full weight bearing, I don't think it makes too much of a difference. If it means, if ever I have general philosophy is, if ever I have to make a mistake, I would rather make a mistake of being too cautious rather than being too aggressive.
I like that. Right.
I'm a fearful man. Yeah, fine.
But it's safe. It's safety. That's what it's all about. I like it. And if a patient wanted, let's say, more than the typical recommended length, and they wanted to go for 2 different surgeries, how long would you recommend if they wanted to do both the femurs and the tibias? How long between the surgeries would you recommend they wait?
In my hands, I would say at least about 6-8 months to a year.
Okay.
Essentially to ensure that they get back in terms of good range of motion, good walking, everything should come back to normal, and then you do the next part.
Okay.
Because the more lengthening at the same time or within a short span that you add, the more the soft tissues have to cope with. Then you require a whole lot of inputs in terms of therapy and stuff like that, which for the individual lengthening, I think is manageable. For combined stuff, you need a patient who's committed. You need a whole therapy set of people who are of a different level. I don't think we have that pressing need at the moment. So our system right now is relatively. We've got good therapists. We've got a bunch of 3 therapists who come in sort of turns, but still we are a little bit old-fashioned, I would say, on that.
I see. And how often do they have to do physical therapy? Is it every day that you mandate that?
Usually what they're doing is doing therapy while they are in hospital. The therapist is guiding them, pushing them.
Yeah.
If we are happy with the way that they are doing things, then they continue doing it at home.
Okay.
And we keep a check when they come back for follow-ups, etc. Maybe every 12 to 15 days. If they're doing well, then they just get a visit from the therapist. They go to the therapist when they come for a follow-up.
Right.
The therapist checks that they're doing everything. Maybe add another level of exercise and stuff. If they are not doing well, then either they get the therapist to come to them, or on rare occasions, I mean, I'm not talking of cosmetic, but I'm talking of even regular releaser of patients. If they're not doing their exercises the way that I need them to, I may even admit them for 4 or 5 days so that they have twice a day therapy and they get back into the proper gradient. And then they go back home and continue it. But those are few and far in between.
Right.
Once they get going on the exercises, most patients ultimately they themselves want to get better.
I see.
So I rarely see a lack of involvement from the patient's point of view.
And as far as pain management goes, do you have a certain protocol in place to help your patients manage from immediately after the surgery for the first few weeks when the body's kind of recuperating?
Yeah, for the first couple of weeks, we take a lot of care in terms of how we make our incisions and stuff. Then the use of local anesthetic in the incisions. Sometimes, depending on the surgery, an epidural for the first 2-3 days so that they can start moving without pain. For about 7 days or so, I will use anti-inflammatories, something like diclofenac and things like that, to ensure that the inflammation settles down quickly. But usually after 2 weeks, then we try and limit to simpler medications like paracetamol, tramadol, or things like that, because non-steroidals, at least theoretically, have been shown to have some risk with bone formation. But we put a lot of importance to ensuring pain relief, because if the patient is painful, they are not going to be able to do the exercises well.
That makes
But
sense.
we will tailor it according to need. I would say 90% get along pretty well with just paracetamol after the first couple of weeks.
Okay.
As lengthening progresses, as they get towards the end,
Mm-hmm.
things can become a little tight, more of discomfort bordering on pain.
Mm-hmm.
But again, there is a mixture of medication, a little bit of a pep talk, explanations as to why this is happening, and they get through that period.
Right.
So I've never had a patient yet. So the thing I like to tell patients is it's not pain less,
Yeah.
but I've never had a patient tell me, "Oh, I wish I never had gone through all of this." So there's never pain to the extent that they regret whatever it is that they are
Well,
doing.
I see. I see. And for your, let's talk for your discrepancy patients, because I have people who watch for that as well. For a patient who has a large discrepancy in one of their limbs, let's say their femur of, let's say 10 centimeters, do you typically split it among the femur and the tibia, or do you just do the femur as much as possible, wait till it heals, re-osteotomize, and then do it again? What's your
Yeah.
protocol?
Usually we would discuss it with the patient in the sense that if there's 10 centimeters
Mm-hmm.
and you do 5 centimeters in the tibia,
Mm-hmm.
then your knees are going to be mismatched.
Absolutely.
But 5 centimeters of a mismatch is something that is kind of tolerable.
Mm-hmm.
And tibial lengthenings are relatively easier.
Mm-hmm.
So depending on what the patient wants and how much is the length to be achieved.
Okay.
So if it's like 6 and 7 centimeters, I would say, okay, do all of it in the same bone. But then if it becomes longer,
Mm-hmm.
then the patient has that option. And usually we come to a decision based on a discussion
Mm-hmm.
and also my suggestion.
Okay.
So normally it would be if there are large discrepancies, you can consider up to about 5 centimeters
Mm-hmm.
in the tibia, because lengthening large amounts in the femur. This I'm talking of
Yeah.
external lengthening, right?
Excellent. Mm-hmm.
If there was a 10 centimeter lengthening in the to be done in the femur and the patient could afford to do a precise, for example,
Mm-hmm.
I would probably lengthen him the max
Mm-hmm.
that I could, and then go back again and lengthen it again with the precise itself.
I see. Because it's in there.
Good, good. Yeah, and it's a relatively straightforward
Procedure.
method. But
I-
10 centimeters with an external device
Yeah.
becomes a problem.
I gotcha. Very cool. And as far as complications go, you mentioned at the beginning that no surgeon has 100% complication-free rate. But have you seen any major complications in your cosmetic patients so far?
No, touch wood, we've not. One patient, which was years ago with an external fixator,
Mm-hmm.
had a delayed
Mm-hmm.
healing for which he required a bone grafting.
Bone graft, yeah.
Most of the other patients who had, say, fixators,
Mm-hmm.
towards the end of lengthening, they will develop a little bit of equinus, or the foot not going into dorsiflexion, just staying at neutral.
Okay.
Mostly they do develop about 5 degrees of equinus.
Mm-hmm.
But that with time and exercise,
Yeah.
that will work itself out. So I don't count that as a true complication.
Mm-hmm.
But we've not had any nerve injuries, no vascular injuries,
Mm-hmm.
no permanent complications.
Mm-hmm. Wow, that's amazing. Really cool.
One of the first patients that I had done, which was very long ago. This was a patient who came to us from another orthopedic surgeon.
Oh.
And so we did that, and then he was supposed to go back to his city and stay under the care of the other orthopedic surgeon.
Right.
And this patient was told about all the 6 centimeters and stuff, but the patient wanted 8 centimeters. So he decided that the doctors don't know enough, and he didn't go to the other orthopedic surgeon and kept distracting till he was 8 centimeters.
Oh no.
He developed an equinus, and then it took 2 years,
Hmm.
I tried first with physiotherapy and all that. Nothing happened.
Yeah.
And then at the end of 2 years, we had to do I came to know almost a year after actually.
Uh-huh.
So then we had to do a equinus correction by a tendo Achilles
Hmm.
percutaneous release. So that in that sense is a complication.
Yeah.
But I learned from that in the sense I generally now avoid if when I do patients, I want them to be in Mumbai for the lengthening period. We've
Oh.
made a couple of exceptions for some of the precise patients
Hmm.
where we've allowed them to go back home and send us X-rays and stuff.
Yeah.
But the precise can be relatively speaking controlled in the
Okay.
sense that someone has to program that ERC.
Hmm.
So if I program it for 6 centimeters, he can't go to 8 centimeters
Hmm.
unless he comes back to me.
Nice. Right.
So in that situation, it may be probably safe. But as a philosophy, I say because all the problems that have to occur during a lengthening
Hmm.
generally will occur during the lengthening phase,
Right.
not when the bone is consolidating.
Oh,
So
okay.
if you are close to me when you are in the lengthening phase,
Hmm.
then
I
you
see.
are more or less through. Then it's just a matter of time, waiting till the bone heals.
Right. And during those checkups and stuff like that, you want them in Mumbai for it depends for the whole lengthening phase. So is that you set that in place like a definite they have to stay there?
It is something that I
Kind of.
like,
Yeah.
but see what happens is as things change, as say for example a patient from India,
Hmm.
you know, um, the other side of Mumbai, it takes about 2 hours to drive down to my place.
Right.
And if somebody is there who is in Delhi,
Hmm.
Delhi is a 2 hour flight from Mumbai.
Okay.
So somebody who's willing to fly to Delhi and fly back
Yeah.
for the visit, it turns out to be simpler actually because there he's at home
Right.
and he just has to come here for a day.
Uh-huh.
It makes sense.
Okay.
One of the lengthening guys that I told you from the Middle East,
Hmm.
he went to the Middle East,
Yeah.
but that's only a 4 hour flight away.
Okay.
If it is somebody from the US,
Yeah.
which is almost 19 hours,
Hmm.
26, 27 hours, I think.
Yeah.
It's not that easy. And then the most important thing is who's going to take care of him there.
Ah, that's true.
If at all a problem happens, then people would say that no, this is not my problem. Fair, I mean they're right in that.
Yeah.
So for those kind of patients, I would prefer that they be here.
Hmm.
So there are issues relating to how you will stay in Mumbai. We're trying to look at how we can work that out.
Hmm.
It's not very simple because in Mumbai you don't get uh, flats or you don't get apartments on short-term rentals.
Oh,
But we are talking to a couple of people. We'll see. Probably we'll work out some method where
yeah.
it makes it easier for people to stay.
At an affordable rate. I see. Yeah. A lot of clinics do that. And as far as let's say that a patient was traveling and do you have any fear of let's say embolisms or anything like that? A lot of patients are worried like
Long,
okay,
yes,
yeah.
long travel. That is always a risk.
Okay. And
So anyway, they wouldn't go for at least 4 or 5 weeks.
right.
Not that soon.
Oh,
Even if there was somebody who was going, they wouldn't go in the first 4 or 5 weeks after surgery.
okay. That's what I was going at. Okay. So that's how you avoid that. Very cool. Okay. Dr. Parhar, a lot of cosmetic patients, they may ask you about their proportions. I've gotten asked a lot about that. What type of advice do you give them that best ease their mind? Do you give them preoperatively? Do you talk to them about like if we lengthen your femurs, it may look a little like this, or if we lengthen your tibias, it may look a little like this, and then they say, oh, but now my arms are too short. What type of scenario do you come up with your patients to kind of help them ease that concern?
A lot of patients know more about proportion, I think, than I do. I mean, there are patients who are talking of proportion in terms of their clavicle and stuff like that. I know nothing about that. I know the ratio of the femur to the tibia,
Right.
and I know that as far as your arms go, your arms need to get into your pant pockets.
Right, right.
So as long as you're within that, I think within the limits that we are talking about, it probably doesn't make any difference. If you're talking of, even a normal ratio of the femur to the tibia,
Hmm.
lengthening it by about 8 centimeters, it doesn't really affect the ratios that much, at least visually.
Okay.
Secondly, you are wearing clothes.
Yeah, yeah.
With that, how you put your trousers on,
Hmm.
I mean, people who are short generally
Yeah.
will tend to put their trousers a little higher
Hmm.
just to make the legs look
Longer.
longer.
Right.
So these kind of tricks, should I say, are always there. So I don't think I'm not. I will explain to them as to, okay, these are the proportions if they have a question,
Hmm.
but I don't think it's a really a big issue.
Right. Yeah. And I've heard that from most other surgeons. They say that most patients after the surgery, they don't even think about it. It's more of a worry that they had before the surgery.
Yeah.
Very cool. Now, another big concern for patients, and I know that you mentioned this earlier, is that the cost of the procedure. Obviously, the internal is more expensive than the external. But do you mind giving for the viewers some of your clinic prices for the different procedures that you offer?
See, overall, in terms of cosmetic lengthening, in Indian rupees, it's about rupees 900,000. We call it a lakh over here.
A lakh, yeah.
Yeah, that is essentially the cost for in to out
Hmm.
for the hospitalization.
Okay.
There are relatively minor costs for the follow-up visit, the X-rays and all that, which in total doesn't really amount to much in the sense of, say, 6, 7 follow-up visits and physiotherapy and stuff like that.
Okay.
It doesn't count for much. This 9 lakhs is the bulk. Now, that may change a little in terms of how the currency fluctuates.
Mm-hmm.
That includes when we are using only a fixator, that includes the cost of the fixator.
Okay.
Otherwise, the cost of this thing, of a precise
Mm-hmm.
or a stride, is added to that
Right.
cost. So, but that cost includes all the other, medications that you receive in hospital, the physiotherapist, while in everything that is in the hospital.
Mm-hmm. It's included.
So that is.
I see. Very cool. And after distraction phase, I'm going to talk a little bit about physiotherapy because that's super important. And you said you guys have a really good team there. And you mentioned that the physiotherapy is included in the cost. But after distraction, when they start to heal the bone, are they able to do their physical therapy on their own, or do you guys give them like an exercise plan? What type of regimen
Yes.
do you?
Essentially, we give them a plan which they carry out themselves. That's what I said. That when they come,
Yeah.
they see when they come for a follow-up, they see the therapist who kind of checks that, okay, they are going according to the plan. They're not having troubles with it.
Mm-hmm.
And if they're doing well, then maybe add something in terms of the exercise plan, or add something in terms of repetitions or stuff like that.
Okay.
And if they are not doing well, then we will get a therapist to visit them. Most of my Indian patients, I will liaise with a therapist in the locality who can go home and do home visits, etc.
Okay.
Or any therapist that they know in their locality, I will, speak to them on the phone, explain what I need and stuff like that. But patients who are under our care here or staying close by, they come to the hospital and see my therapists in the outpatient.
Okay.
So there is a plan. We have very specific goals that we want in terms of stretching, in terms of strengthening, all of that.
Okay. And the physiotherapists make sure they have that. That's really good backup. And for patients that ask about how soon can I walk, let's say a patient went for the 7 centimeters on the femur or 5 centimeters on the tibia. After they start to heal the bone and you're confident that that bone is strong and healed, it filled in the gap, when can they expect to regain a normal walk? Because obviously we know that the bone is fine.
The honest truth is, I think if you're having a cosmetic lengthening, what I tell patients is you are not going to be normal before 1 year.
1 year. Okay.
Yeah. And that's the time where you are free. You may get free of crutches, but your rhythm, the way that you walk, the smoothness with which you walk, you cannot come back to normalcy much before that. I think even if you're if you're extremely committed, huge on your therapy and stuff, maybe 7-8 months.
Right. Yeah.
At the earliest.
Yeah.
But to be walking in a crowd and someone who knows you doesn't realize that this guy has had something done, I would say a year. So again, this is part of my cry wolf strategy, in the sense, prepare you for the worst. If you get better quicker than that, lovely. But you're going into it knowing that, okay, up to this much time, I can take. You had a lengthening yourself, right?
Yes. I had a discrepancy though.
And how long was it before you got completely normal?
It was about 6 months for me, but I had it wasn't cosmetic.
Exactly. So it was one side.
Yep. It was one side.
And you are a very, obviously a very athletic person in that sense. So for a person of your caliber, if it takes you 6 months to recover fully,
right?
Someone who's not that athletic, definitely going to take longer.
Okay. That's good. Yeah. And that's why I tell them, I say 6 to 8 months, maybe longer, but you got to be dedicated on that therapy. Very cool. And you mentioned that patients should stay in Mumbai for the distraction phase. You also, I've heard other patients say that Dr. Parihar recommends that they have a helper with them, somebody to come with them during the lengthening. Is that also something you recommend?
No, we've done the people who've been out of town for us, the cosmetic lengthening. We've done them without. Meaning we've been their family, so to speak.
Okay.
I mean, one of the first guys that we did, I think he, on the day of surgery or the day after surgery was his birthday, I think. So we got him a cake, took pictures of him with the cake, sent those pictures to his mom and stuff like that.
That's awesome.
But that's ultimately, see, that is what, this is a patient who's come all that way, putting his trust in us. So quite apart from the fact that we have to, ensure that whatever faith he has put in us is not misplaced. That's number one. But then ultimately, while he is here, then he has nobody else except us. So it is our kind of duty in that sense to look after him.
Okay.
Why I say that you have to have somebody with you is, in India, one is that sometimes people will have the idea that, okay, I can get it done without informing my parents or a loved one or a significant other. And this is a very demanding, demanding procedure emotionally. It requires a lot of emotional support. If you don't have emotional support, then you can go haywire. And I've treated 3-4 other patients, treated with lengthening elsewhere, where a patient comes in here thinking that, okay, I need to get 6 centimeters of lengthening. So 65 days. And at the end of 80 days, I will go back to America and I will join the fall semester or whatever. And then at the end of 80 days, he's got a flexion deformity of the knee and an equinus contracture, and he's got infection in the pins. He's got pain. Mom and dad are there. It's a mess. It's a complete mess. So the reason for asking for a helper is to ensure that there is someone significant in the family who knows what is going on. Interestingly, there was a case in India where somebody got a lengthening done in a city called Hyderabad, which is the south of India. and this guy has not informed his parents. When the parents, then they started searching for him because he kind of went missing.
Mhm.
They found him in the hospital,
Mhm.
and he was in bad shape because the lengthening was going on and he was not ready for it.
Uh-huh.
So now in that situation, the whole thing was turned onto the doctor, that how can you do something like this, etc. But basically, my goal here is that this is, and so normally when I'm explaining all of these things, especially if it's younger people in India, we don't leave the family very early. In the West, you tend to become independent quicker.
Uh-huh.
So I will insist that either a brother, sister, or a parent
Mhm.
is there
Yeah.
to listen to that whole list of complications, possible complications, etc., that I recite.
Mhm.
They are listening to it, so that, because when you want something, you are only listening to the good side.
Yeah, that's true.
You don't. I say that, okay, you can have an embolism.
Mm-hmm. Yeah.
Okay, it's not going to happen to me.
Mm-hmm.
But
Yeah.
I did say it. You didn't register it. That is where the problem comes up.
I see.
So that's the reasoning behind it. Not to. And sometimes there is also what we call a medical legal thing. Suppose something happens. Suppose there is a complication.
Right.
Then what?
I see.
So but for patients who are international,
Yeah.
we look after them. That's not a big issue.
It's not a problem. Okay, so it's more of a like kind of a coping mechanism versus a mandated mechanism. I see. Very cool. And I kind of want to ask this question. A lot of patients always wonder from a surgeon's perspective is, do you feel that there's going to be any long-term effects on the bones or soft tissues after a cosmetic procedure? Let's say like after 5 centimeters in the tibia, like maybe arthritis in the knees, or hip problems, anything like that? Or
No, I don't think so. If the lengthening has gone off peacefully without too much of trouble in terms of therapy and stuff, I don't think it's going to it's going to create, because here what's happening is the tissues are adapting.
Okay.
Now I think we've had enough experience, say even with not cosmetic lengthenings, but say congenital lengthenings and stuff, where at least for the medium term, they don't have any major changes in terms of arthritis and all, as long as overall alignment issues and all are okay.
Right.
There should not be any problem. One thing I don't know, because I have no experience, and probably some of the other guys who are doing more would be able to say, which I get asked quite a lot, is what about my sports?
Yeah.
Or what about my sporting level? Will I be able to get back to that? I don't have a simple answer to that. I think you could, but I have no personal experience, say, of a patient who was at a very high level in terms of sports,
Right.
and then had a cosmetic lengthening and then went back to that. The patients that I have operated are, regular guys who want recreational sport and stuff, but not to a very high level of skill.
I see. Yeah, I definitely am following with a few patients to get that data. So if I have it, I'll send it along. All right. Well, Dr. Parihar, that was an amazing interview. You're one of the most experienced limb lengthening surgeons in the world. Top surgeons, several patients appreciate you for your passion, care, and expertise in the field. And so for anybody who's looking for limb lengthening, whether they're from India or elsewhere in the world, what's the best way to reach out to you and contact you for a consultation?
The best way is our email. I know you had some problem getting through on that email. I don't know why it didn't come through, but that email of, you can put it into your comments. It's info@bonedocs.in.
Okay.
That is the best way. I'll pass on WhatsApp number also to you.
Okay.
But I think email is the best, because we can keep track of it.
Okay.
Generally, we have a system of kind of ticketing, so we keep a track of things that haven't been answered and stuff like that. That's probably the best way.
The best way. And do you have a website as well?
I do have a website which has which is a little dated now. We'll try and correct it. It's called elizarov.in.
Okay.
But a lot of this information which I gave you now in terms of lengthening and all, we've got a little mini site where we've got a page related to cosmetic lengthening,
Okay.
which we keep updating in terms of all the pros and cons and the costs and stuff.
Mm-hmm.
So when someone asks us about cosmetic lengthening,
Mm-hmm.
we generally send them a link to that page. I'll share a link
with me
to that also with you on email, and then you can put that in the comments.
Absolutely. I'll be sure to post all of your contact information in the show notes so everybody can reach out to you through that way. Dr. Parihar, are there any final words you'd like to say to anybody who's looking for limb lengthening with you?
Looking for limb lengthening or looking for limb lengthening with me?
Both.
So I think the bottom line that you need to look for is to look for safety. I know there are people who have issues in terms of affordability and stuff like that.
Mm-hmm.
But I would say, waiting for 6 months, 1 year, if need be,
Mm-hmm.
And trying to do something that is safe
Mm-hmm.
is much better, because we've seen patients who haven't done well with cosmetic lengthening, in the sense XYZ does it,
Mm-hmm.
and then we are seeing the problems, bones are not healing and stuff like that. So it's always better to be safe.
Mm-hmm.
And go in, slow and steady. Don't kind of rush into it. Do your research. It's not necessary that you will come to me.
Mm-hmm.
Do your research and choose a doctor that you feel comfortable with, that you feel confident with,
Right.
and who's got a sort of track record, of using the elixir.
Absolutely. That's a great way to end it. All right, everyone. That is Dr. Mangal Parihar of the Center for Limb Lengthening and Reconstruction at the Mangal Anand Hospital in Chembur, Mumbai, India. Dr. Parihar, thank you so much for your time.
Thank you. Thank you, Victor.
I hope you enjoyed that interview with Dr. Parihar. With over 30 years of experience and a philosophy of function over length regarding patient safety, it's no wonder he's one of the top leading surgeons in the field of limb lengthening and deformity reconstruction. If you're interested in reaching out to Dr. Parihar, you can find all of his contact information in the show notes. Until next time, this is Victor from Cyborg for Life, signing out.